welcome to all of you who are joining us live on Facebook and through Zoom. I'm really delighted to be moderating this session today. I'm also extremely grateful to all our panelists who have joined us today from across the United States, Paul Lombardo, and from all parts of Pakistan today. I'm going to be introducing the panelists one by one as we come to their individual talks. But what I would like to do is just begin with sharing with all of you that as of 9:50 a.m. today, almost 36 million Pakistanis have been administered 1 or 2 doses of a COVID vaccine. Now that doesn't really, unfortunately, place us too high up where we compare it to other parts of the globe and other countries. Just over 2% of our population is fully vaccinated at the moment, and we're actually ranking as one of the lowest countries in terms of vaccine uptake and not only first dose, but also fully vaccinated individuals. We're seeing a new wave, we're seeing a surge of cases again in Pakistan, and this is our 4th surge. We're also seeing new variants, the Delta, and recently identified the Epsilon variant in Punjab. We've seen other headlines that doctors are also now again dying of COVID. And this report from the Dawn yesterday basically highlights the fact that one of the doctors who died was actually fully vaccinated. And it brings the total of physicians who lost their lives to COVID in Sindh to 73 since COVID started. Other headlines such as boosters for healthcare workers, the fact that COVID reinfections are occurring in vaccinated individuals are also a cause for concern. It's kind of also really kind of brought about measures that the government has started to take in order to try and encourage people to be vaccinated. And that includes mandatory vaccination for domestic air travel, making it mandatory for school teachers and staff to be vaccinated against COVID. And very, very recently, which we saw a huge surge in people trying, not only trying to get vaccinated, but saw a huge influx of people going into various vaccination centers in Karachi. And this was in response to the fact that the Sindh government actually threatened to switch off mobile phones and block SIM cards for people who were not vaccinated, and also mandated that any public sector officials would not be allowed to come to work if they had not been vaccinated. But this brings us to lots of questions, and it brings us to the, to sort of question, well, what's at stake here? We've got to deal with the pandemic as a public health emergency, but we are now sort of stepping on individual rights as well. It is a public health global emergency. It's not just about individuals, but this whole idea of mandating vaccines and mandatory vaccination, it really questions when we start to talk about it in healthcare workers and other professionals, we're actually pitting individual autonomy against their duty. We have a number of different opt-out policies rather than mandates that are being implemented across various sectors of the service industry. Now, whether these opt-out policies are coercive or invasive, and especially if they're linked to any sanctions, as we've just seen from those headlines, that also brings a lot of things into question. So the idea behind today's webinar is for us to provide information about the vaccines available in Pakistan. How safe are they? How well do they work? Really just to be a little bit more well informed about how are they working? How well are they working? How well are they protecting people who have been vaccinated? To also provide an overview of the context of rights in a public health emergency. So here we're talking about, should we just leave it up to individuals to choose whether to be vaccinated, or do we push it as an obligation that they ought to be vaccinated? And who decides, who defines this, and the idea of common good? And does the common good trump best individual interests? We're also going to be discussing some consequences of mandating COVID-19 vaccines. and to also be aware that there are challenges of implementing vaccination policies, not only in institutions, but across all sectors of Pakistan. So whether private or public sector staff required to be vaccinated, whether it's teachers or healthcare workers, how is that being rolled out? Again, it's bringing into question their duty to serve as opposed to their own individual rights. And really how some of these opt-out policies are tending to be more coercive and invasive as opposed to being a little bit more inclusive. So I'd like to start off. I'm going to stop sharing my screen now. And I'm going to invite our first panelist. And I'm absolutely delighted that despite being extremely busy, she agreed to accept our invitation to be a panelist today. So Dr. Bushka Jamil is Professor of Medicine at the Aga Khan University, Karachi. She is also the National Coordinator of the Crisis Management Unit at the Ministry of Health, National Health Services Regulation and Coordination Services. And she's also serving as the President of the Medical Microbiology and Infectious Diseases Society of Pakistan. So Dr. Bushra, over to you. Dr. Bushra, you're on mute. Can I?
So thank you very much for your invitation and your introduction. So I will start sharing my screen. So these days I'm in Islamabad, so I regularly attend NCOC meetings. So I'm very familiar with the way decisions are being made and data is analyzed. So I'm delighted to be here to talk to you about it and to let everyone know what goes on there and how decisions are made. So to begin with, the questions which come to our mind: why is vaccination one of the most important strategies thought to be effective for ending the COVID-19 pandemic? And what is the science behind the various concepts of infection, disease, immunity, herd immunity, transmission, and vaccine passports? Then, is vaccine availability an issue, and how was Pakistan's vaccine rollout plan decided? Then there is a question of vaccine hesitancy, which I'm not going to talk about in great detail, but I will pose this question to you. Is it real, or is it just a hype? And then the real question: should vaccination be mandatory? And how to differentiate between scientific data and rumor mongering. So why are vaccines considered to be one of the most important strategies for ending COVID-19 pandemic? So vaccines have saved millions of lives up till now and are thought to be the most important control strategy for many infectious diseases. And this has been so for more than a century now. So how do vaccines act? They basically train the body's immune system, the natural defenses, so that when the body encounters a pathogen, it can recognize it and initiate a response to take care of the infection. After vaccination, if the body is exposed to the disease-causing germs, the body is immediately ready to destroy them, thus preventing illness. So then we come to the concept of infection, disease, immunity, and the various aspects of immunity. So what is basically infection? Infection means invasion and multiplication of microorganisms like bacteria, viruses, or other pathogens, which are not normally present within the body. Infection may be asymptomatic or silent, or it may be symptomatic. So disease develops when a person has symptomatic infection. Symptomatic manifestation of infection is called disease. And immunity refers to the body's ability to prevent the invasion of pathogens. However, it is important to realize that immunity is a complex phenomenon, which is often not measurable by a single test. So the thing which is important to remember is people's fascination to get their antibody titers checked after infection or after vaccination. That does not correlate directly with immunity. For COVID-19, prevention of invasion or infection is not possible because the virus is everywhere. And with the new variants coming in, re-exposure is a frequent phenomenon. It's actually attenuation of symptomatic disease, which is the objective of vaccination. So what are we trying to do? We are trying to prevent symptomatic infection, and we are trying to prevent development of serious disease, which may require hospitalization and death from COVID-19. So these are the basic targets. This brings us to the question, do vaccines block transmission? And the answer is probably no. Vaccines may reduce transmission, but people can still carry the virus. They may be asymptomatic. They may continue to transmit infection to other unvaccinated individuals and may actually cause disease in others. Then we come to the concept of herd immunity. Now, a few months ago, the concept of herd immunity was being continuously challenged as something which we should not aim for. But herd immunity actually means population immunity and indirect protection from an infectious agent that happens when a population is immune either through vaccination or immunity developed through previous infection. And to safely achieve herd immunity against COVID-19, a substantial proportion of population would need to be vaccinated, lowering the overall amount of virus which is able to spread throughout the whole population. So the percentage of people who need to be immune in order to achieve herd immunity varies with each disease. So citing two examples, one is that of measles, which is highly transmissible. That requires immunization of 95% of population. So if 95% of population is vaccinated, the remaining 5% will be protected. For polio, the threshold is about 80%. For COVID, this has not been figured out accurately as to what proportion of population would need to be vaccinated to induce reliable herd immunity. So this is an important area of research and will likely vary according to the community, the vaccine which is being used, and the populations which have been prioritized for vaccination, and many other factors. Achieving herd immunity with safe and effective vaccines make diseases rarer and save lives. So this should be one of our objectives. And we should be aware of rumor mongering, because there are many groups who've been talking against achieving herd immunity, which is surprising, but that has happened. So then we come to vaccine passport. So travel now requires documentation of evidence of vaccination. This was true of international travel, but now national travel, intercity travel also requires evidence of vaccination, either first dose or both doses together. And only then they allow passengers to board the flight. But the question is the world ready for it? WHO currently does not recommend vaccine passports for international travel because vaccine availability then is linked with production capacity and cost of production, transportation, storage, and administration. And it requires tremendous human and financial resources. Vaccine distribution among countries has not been just and equitable. So imposition of vaccine passports is like penalizing countries which have not been allowed a fair share of vaccines. So let's come to vaccine availability and rollout plan in Pakistan and what is the best vaccine. So luckily, during COVID-19 pandemic, the decision makers have been infectious diseases specialists, scientists, epidemiologists, pharmacists, and many other relevant groups who constitute vaccine expert committee and are members of NCOC and other committees. So Ministry of Health Services in collaboration with NIH Islamabad and DRAP and many other collaborating institutions have been working together to chalk out guidelines and to make decisions which are most relevant for our context. So NCOC, which is National Command and Operations Center, is a platform where countrywide data is analyzed daily and objective decisions are made on COVID-19 control with input from experts. And because of that, WHO has said that Pakistan is among countries from whom the international community should learn how to deal with COVID-19 pandemic. So if you look at our rollout plan, our initial reliance was on COVAX. Manufacturing capacity, cost, political affiliations are all important factors, but we were relying on COVAX because of the message which they sent across the globe. So COVID-19 vaccines global access is abbreviated as COVAX, which is a worldwide initiative aimed at equitable access to COVID-19 vaccines, as directed by Gavi, which is again a vaccine alliance and coalition for epidemic preparedness innovations, and WHO. However, as the situation unfolded, we realized that COVAX had a limited role in Pakistan's vaccine rollout strategy because they were not able to fulfill their promises. Then different vaccines started coming out with tremendous storage transportation issues and very stringent requirements. Then there was the issue of identifying the most vulnerable groups for COVID-19. And it was decided that vaccination would be rolled out in phases rather than as a priority. So what was decided that in the best interest of the people and in the situation of limited availability of vaccine, what is the most vulnerable population? Who are the people who are most at risk? And it was decided that frontline healthcare workers are most at risk and they are repeatedly exposed. So with limited vaccine supply, they will be the first ones to be offered vaccines. Then came the issue of vaccine procurement. So in the initial days, only China was talking to Pakistan. So Sinopharm was among the first vaccines which came to Pakistan. And even these vaccines came in limited numbers. So frontline healthcare workers were offered these vaccines, and this was followed by Sinovac, AstraZeneca, CanSino was here because of trials, but then it became part of the vaccine rollout strategy. And this was followed by Pfizer, and now we have Moderna, and there are others in pipeline as well. So starting from February, frontline healthcare workers were offered vaccination first, then healthcare workers in general, and then came the other segment of susceptible population, and these were the elderly. And as vaccine supply became more abundant, vaccine was offered to younger age groups as well at regular intervals. So the currently available vaccines, as I've told you, Sinopharm, Sinovac, and Sputnik, availability has been erratic, and that has to do with problems in their manufacturing plant. Then AstraZeneca, Pfizer, Moderna, and Johnson & Johnson is also in the pipeline. Now we come to the concept of vaccine efficacy, which basically means % reduction in disease incidence in a vaccinated group compared to an unvaccinated group under optimal conditions, example, that of randomized controlled trials. A vaccine may have efficacy of 95% and above, but the vaccinated person may continue to carry the virus after vaccination. So there are so many vaccines available for one virus, how to choose which is the best one for us. So factors to consider whenever you are selecting a vaccine, apart from vaccine efficacy, is age. So a vaccine which is good enough for infants and children, for instance, may not be good for adolescents or adults. Then we have to consider special conditions like pregnancy and individuals who are on birth control, especially in the context of some vaccines like AstraZeneca and now Johnson & Johnson, which are associated with rare blood clotting disease. Then we have to consider chronic medical conditions and people who are immunosuppressed. So all COVID vaccines are either component vaccines or mRNA vaccines or contain just a portion of the genome. So these are not live attenuated vaccines. So they are generally safe in immunosuppressed, although the level of protection may not be optimal in such people. And all these factors have been considered in the guidelines which have been prepared by the Ministry of Health in collaboration with the experts. So vaccine effectiveness in contrast to vaccine efficacy. tells us about the ability of vaccine to prevent outcomes of interest in the real world. So the data is now available for most of the vaccines, and it has been shown that almost all the vaccines are effective in preventing hospitalizations and death from COVID-19. 2 doses are good enough, but more doses may be required. Data is being collected by different groups, and soon we will know whether a 3rd dose is warranted or not, and what would be the optimal interval of giving 3rd or additional doses as boosters after completing a full course of vaccines. For most COVID vaccines, immunity at 12 months is being studied, but aiming for lifelong immunity would be impractical because the virus is changing. And for coronaviruses, this is a known feature of the virus itself. And we should take our lessons from the veterinary sciences, where this pattern of infection coming in waves because of viral mutation have been known for a long time. So vaccine may remain effective even if 2nd dose is delayed or missed. This has been shown in many studies and for different types of vaccines, more so for mRNA vaccines. Administration of improperly stored or expired vaccine generally only results in reduced or no efficacy, but serious adverse effects have not been noted. But this is an important issue which should be kept in mind when we are studying patients for reinfections after vaccination. So if you look at the protective effect of COVID-19 vaccination in Pakistan, our data shows that people who have been fully vaccinated have had an incidence of 0.04% reinfections, as opposed to those who have never been vaccinated. So an unvaccinated person has 7 times higher risk of contracting symptomatic COVID-19 infection as opposed to somebody who is fully vaccinated, and fully vaccinated people generally have a lower risk of developing symptomatic infection. The risk is low, it's not totally absent, and this we have known even before rolling out the vaccination program. Then we come to this important question: should vaccination be mandatory? Mandatory vaccination means compelling vaccination by direct or indirect threats of imposing restrictions in cases of non-compliance, and that makes it an ethical issue. So it is a matter of individual choice versus greater good of protecting both vaccinated and unvaccinated population, and this demands dialogue, and that is the objective of today's webinar. So to conclude, vaccination is an important strategy to control COVID-19 pandemic worldwide. We need to stay informed for new developments and directives. Policies and guidelines are being prepared by subject experts in Pakistan. Vaccine rollout in Pakistan is the result of a well thought out plan and is being regularly reviewed and optimized. Every effort should be made to keep the strategies ethical. Thank you very much.
Thank you very much, Dr. Bushra. That was a great overview of what is happening in terms of vaccine availability and the different vaccines that we have in Pakistan at the moment. And it was really wonderful to see the data from our own population, and that's really fantastic. So it's very, very good to see that, you know, we've got that factor of 7. So if you're unvaccinated, you're 7 times more likely to get severe infection from COVID-19 as opposed to if you're fully vaccinated. That's really, really important. So to help us move on to looking at a slightly different aspect of the question of mandating vaccines, I'm going to now invite our second speaker today, Dr. Paul Lombardo. I am just quickly going to pull up my screen. Sorry, apologies for the delay. So Dr. Paul Lombardo is Professor of Law at Georgia State University College of Law, and he's the former Senior Advisor to the Presidential Commission for the Study of Bioethical Issues in the USA. Paul, I'll hand over to you now.
Thank you. Thank you so much for inviting me, and excuse me. And I appreciate this opportunity to see so many, the faces at least of so many old friends and colleagues. I'm going to talk a bit about the law, but I think those of you who know me realize I'm not an expert on the law in Pakistan. But I want to summarize what I think the situation is, both there and to a certain extent worldwide, but more specifically, how we look at things here in the US. I believe that it's true that the provincial legislatures have the right to make specific rules in Pakistan, but they may very well be overruled at the level of parliament or the prime minister. This is not unusual. I think that the situation in most countries with a parliamentary system allows for a kind of centralized control of public health issues and through a health ministry. That is somewhat in contrast to the patchwork of things that we have here in the US, which I'll try to explain a little bit later. But there have been occasions as recently as 2015 where vaccination for polio, for example, was linked to school attendance in Punjab and other provinces, and then the national government got involved. And the mechanism for doing that, you all know better than I do in terms of acquiescing when two different provinces agreed. I think that there's another important point here that we have to take into account. I think this is really critical. In Pakistan, of course, there needs to be a consistency between religious belief and the kinds of laws that are passed, and you have various individuals and ministries who look at those issues. But happily, I think there's been a general universal acceptance of both the need for and even the obligation for vaccination. There have been a series of fatwas that have been issued, not just in Pakistan, but around the Islamic world from various different religious groups, and they're all consistent in saying that there is no reason to refuse, beyond a medical reason perhaps, but there's no moral reason to refuse vaccines. And so that means that it is both appropriate and in some cases, as I said, even obligatory for health and safety. That becomes an important issue in terms both of acceptance and of how we think about the ethical issue that what we're talking about as mandatory vaccination poses. So the issue is really less about government power, and I think that's the case in every place, than it is about how the public will react to governmental measures that combat the disease, whether they'll accept them, whether there is opposition that is based in something other than personal preference. For just a second, I want to mention that, as I'm sure most of you know, there are a variety of means that public health authorities can use to suppress disease. We all know about sanitation measures. We can seize land sometimes to dig pipelines to carry sewage away and that sort of thing, to clean the water supply. That kind of thing comes under the public health mandate as well, even though we rarely think of it that way, and it's rarely questioned. We also have a variety of means through law of imposing some kind of seclusion or segregation that sets people who are infected or have been exposed to a disease apart from the general population. And depending on their infectious status, we could call that isolation and or quarantine. Those happen at different stages in the program. And again, those have been used by governments for centuries. The newest provision here that we had little experience with, or at least little recent experience with. I'm reminded every day that in my country, we went through this in 1918 with the influenza epidemic, and that's masks. People find masks onerous, and sometimes a requirement that you wear a mask in a public place or within indoors is something that is challenged, but that's clearly something that the government can do. The harder question is to what extent they can do that in private settings or in private businesses, for example, but that doesn't seem to be something that can be successfully challenged, at least in this context. And then, of course, we have vaccination, which is the topic at hand today. And we'll be talking a lot more about what it means to say that vaccination is mandatory. In my country, we have a problem that is born of two different kinds of segmentation. The first is we have a federal government, we have state governments, which correspond to your provinces, but which have a tremendous amount of autonomy in making decisions. And then we have local governments, and the local governments can make decisions of their own as well, although they can easily be overridden by the state. So when a mandate is issued, the hard question is who has the power to do that in the particular geographical area or legal jurisdiction? And is this a mandate that covers public places and people covered by public law, or is it something that is private? And I'll talk about that a little bit more later. The biggest real issue here, I think, is the issue of bodily integrity and how bodily integrity sometimes conflicts with questions of public health. What range of choices are available to people when something which we call a mandate has been issued? So in this country, in the US, we have a very old early 1900s case called Jacobson versus Massachusetts that involved a man who had been vaccinated when he was a child in Sweden and had a bad reaction. This is in the 19th century, came to America, became a minister, a Christian minister, and was in Massachusetts, in Boston and Cambridge, actually, where during the smallpox epidemic that had been raging along the eastern coastline. And he didn't want to be vaccinated. He didn't want his child to be vaccinated. The child had to be vaccinated in order to go to school, which is a common requirement. The father didn't want to be vaccinated because he said he had a bad reaction the first time. And so he opposed the ordinance that was passed that said he had to be vaccinated if he wanted to live in Cambridge, Massachusetts. The case went all the way through the courts, got to the United States Supreme Court, which said that he did not have a choice in this matter. Now, I want to qualify what that meant. They said that vaccination mandates are common, and that deference by public bodies like health boards to medical experts was also common and was to be expected. That there was a history of vaccination that went all the way back to in this country into the 1770s. In fact, George Washington, the first president, was known to have vaccinated his troops during the Revolutionary War. So this was not something new in 1907. The court emphasized that we make rules that are generally applied to people to protect the health and safety of the society. We make those at the local level and at the state level, and they are absolutely necessary. Otherwise, we will devolve into chaos, because we have to be able to protect the health of the people. Otherwise, the society will simply collapse. And so it would be anarchy to allow individuals to break laws without some kind of consequence in that way. And so from that point of view, mandates are all right, as long as they are conditional. Now, the conditions are the critical thing here. In the Jacobson case, Reverend Jacobson was subject to a $5 fine, a significant amount of money in 1900, but still not an impossible amount. There were other rules that would have allowed people to be excluded from public places, for example, schools, and later on to be excluded from certain lines of work. And there were certainly rules for isolation of the sick or the exposed through isolation and quarantine. The Supreme Court said that all those were fine. The hard question was, what about someone who had a very specific medical complaint, which meant they would be at risk of serious disease or illness only by being exposed to the vaccine? And the courts left that question open and said people with that kind of complaint might very well be able to sidestep the reach of these laws, but that wasn't the case here. We had a man who was talking about a much older intervention, and one which he survived with discomfort, but nevertheless survived. And so the court said that question wasn't presented. So it's that case that we look at for a kind of national view of what the rules are here in the US, which brings us to the current situation. We have some public mandates for vaccination, which are a condition of a job. We now have a federal mandate, which is going to be a condition of in-migration for travelers. We have requirements of masking in public situations like airports or federal or state buildings, and exclusion of unvaxxed people from public buildings, and in many cases for private businesses. Is this a case of forcible vaccination? No, which I think would be a bad idea anyway. The real question is how much incentive or disincentive do you have? How much incentive do you have to be vaccinated? And is it so seriously coercive that you don't have a choice? And that's what we're debating right now. In most cases, though, the so-called mandates that say you have to take a vaccination or lose your job also have an escape clause. And the escape clause is you can be tested once or twice or 3 times a week, and you have to wear a mask all the time. So far, we've not gotten to what I would consider a real mandate. So in summary, I think we'd have to say that vaccination has been approved as a legal matter in most places, that government may require it at various levels as a condition of participating in social activities. And in this country, at least, so may private businesses, almost with no interference by the government. If I decide to open my shop and require masks or require vaccination, I probably can do that. We have a case in Indiana, which the state university did that, and that has recently been upheld by one of the circuit courts, which is a high court below the Supreme Court of the United States. So I think that is the state of the law as we sit here today. I'll stop there.
Thank you so much, Dr. Lombardo. That was a great overview of how things stand right now in terms of who's making these decisions and how these decisions carry. So whether it's a nudge or a push or a smack or a shove that we're going to do, it's really going to be interesting to see how other countries approach this idea of mandatory vaccination. I mean, it seems as though in Europe, there's again, there's been a very varied response. We can discuss that at the end with all of you as the panel, but I'm going to now move on to trying to look at our third objective for today, which is really to try and understand some of the consequences of mandatory COVID-19 vaccination on public health. And I'd like to invite Dr. Asim Ahmed. Thank you so much, Dr. Asim, for joining us today. I know despite a very serious family emergency earlier this week, we weren't sure if you were going to be able to join us, but I'm absolutely delighted that you're here, and thank you so much for still being able to participate. So I'd quickly introduce Dr. Asim. Dr. Asim is the Dean and CEO of the Kidney Center Postgraduate Training Institute in Karachi, and I'm going to now hand over to him to start his talk. Thank you, Dr. Asim.
Thank you very much, Natasha, and thank you, CBEC, for arranging this seminar. Thank God my mother was ill and she is now better, so I'm able to come. I don't have any slides. I hope to go through the next 10 minutes to let you know why the mandates are so contentious, and sometimes I have a lot of issues with individuals, and how individual rights are sometimes overpassed by specific mandates. Generally, public health by itself, if you look at over years, public health has always had a very stormy relationship with individuals, and that was expected. Both public health and clinical medicine, their aim is to have well-being of the individuals at the very core. However, they both approach it very differently. Clinical medicine, by and large, is individualistic. It is decided by the individual or herself to do something. However, public health does these interventions at a larger or a public level or a community level. And sometimes these interventions can be intrusive and sometimes very restrictive. We all know, Paul just mentioned about quarantine or isolation. I mean, it is public health sometimes can take away the right of freedom. I mean, basically they put you to jail. For example, if you enter Pakistan if you've come from an area and where you have yellow fever and you've not been vaccinated, you would actually go to jail or spend 10 days in quarantine, which is really intrusive. Public health does these things for what is supposed to be the greater good of the individuals, and sometimes uses what is called mandates. And actually mandates, the Latin word mandate comes from manus and hand. So basically a superior or a higher level authority does something to others and tells you what to do is a mandate. Mandate is a kind of a political authorization. It's done by political governments or a government in charge, whether it's local, regional, or federal, as Paul was mentioning. It's usually done through a parliamentary action or a thing. By and large, one has to decide when the term that we've been using quite often as mandate, is it truly a mandate or not? Generally, as Paul has also, I think, briefly mentioned, these are not legalistically mandates. These are certain specific requirements which have a sort of a release valve to say you can also do certain things. So it's not mandated that you have to be vaccinated. It gives you a clause to say if you don't get vaccinated, either you can't enter school, or you will have to wear a mask, or you will have to get your nose swabbed 3 times a week or something else. But these are the things that normally, so they're generally not specifically known as, they're called mandates, but I'm not sure whether legally they can be defined as mandates. So mandates are usually policy options. They usually interfere with individual liberty and autonomy. They should ideally be only considered if by doing so, it will actually prevent a greater risk of death and morbidity and spread of infection. And they should ideally only be used in very specific circumstances. And presumably these circumstances are such. These are not part of routine cares. Mandates are not requirements by and large. I personally think a lot of what we think of mandate is actually requirements that people have been put forward to. For mandates, the first thing is that the intervention should have a very clear medical value. You have to have clear medical value to the individual if possible, and definitely to the public. Only then it is. The second, to infringe on the individual liberty or the choices with a mandate, the public health benefit of the intervention must also be extremely clear. In case of COVID vaccine, individual benefits, of course, specific. Bushra mentioned the disease rate, but the public health measures, I am not 100% sure how effective it is. Clearly, with these new variants, we are not 100% sure whether they actually prevent the spread. Unfortunately, asymptomatic or minimally symptomatic people, unfortunately, tend to spread more disease than symptomatic people who are clearly sought out and then put into isolation. The third condition that normally mandates should have is to whether the mandate is the only way to obtain this thing. If there are other measures that can do it, and that may be actually beneficial. To have a mandate, one needs to have what I call, at least, and that many people have written on it, is there has to be certain procedural requirements for a mandate, certain ethical guidance or procedures that should go through before a mandate is rolled out. And the first thing is that it has to be reasonable, which means that decisions are based on specific reasons and on evidence, and that all stakeholders, or at least majority of stakeholders, would agree that they do meet the healthcare needs of the community at large. The second, these decisions have to be open and transparent. Unfortunately, many of these processes that Bushra has defined or desired are not really truly open and transparent. I mean, I'm sure they are all well-intentioned, but for example, I do not know how those decisions are made. And so if you do, and when people don't know how decisions are made, then sometimes they are very wary of those decisions. Ideally, these should be inclusive. So everybody should be, or at least a larger part of the stakeholder community should be included in those decisions. They should be responsive. So that means they have this ability to respond to certain variations where people are decide when and what to do, and what happens when there is a dispute, what happens when there is a complaint, where do you go, and who do you talk to at that time, so that your complaint may be redressed. The second, the fifth part of the whole issue is that whether how are they accountable? How are these decisions answerable, and who acts and answers those decisions? So these are at least the first 5 reasons or 5 things that one knew, procedural things that need to be done. Then if you consider the vaccination or COVID vaccination, by and large, most public health measures go through what is, a lot of you would know is the harm principle, the harm principles, which states that you can only do these things which are intrusive. Exercised by an authority is only when there is clearly evidence that this will help the greater good and people will have it. And it's not necessary that it's for the individual. What it means is that there is a larger community benefit. So if you look at these mandates, one has to say, there has to be a clause or a principle or whatever you want to call it of necessity. So the first thing is that you should know that it is necessary to get vaccinated. And these things would have achieved a certain goal. And the goals could be public health and presumably, and sometimes it could be economic goal. So you can say if you have a lot of symptomatic spread, the economic activities will go down. So therefore, the overall for the greater goal, you may need to mandate certain things. But to mandate vaccines, as Bushra was explaining, you need to be sure that the vaccine is effective. Number one, you have to have clear evidence that the vaccine is effective, and mandatory vaccination is considered necessary to interrupt transmission if this is our public health goal. If the public health goal is to restrict transmission and prevent infections to others, that is one of the goals that I presume we have, and we have to be sure whether it does that or not. If it does that, then it's fine. Or if our public health goal is that we want to save our public health, the healthcare system, and we do not want to overburden it so that the healthcare system is not, and we have to be clear whether that's our thing. The other thing is that we have to be sure that it's safe. The vaccines, the safety of vaccines, I mean, I can challenge the safety of vaccines. If they are so safe and so effective, why aren't they not registered? Why are they still, so if they have not met that bar for becoming a registered vaccine, there is in many individuals and even in healthcare workers, there is this doubt that these vaccines may not be as safe because we don't know the long-term effects, and they may not be as effective because it's a very short-term trials. So there is an issue of thing, because the counter argument is if they were so good and so safe, why would they still continue to go into emergency use authorization or have an emergency authorization? And of course, what Bushra meant, you have to have a reasonable amount of supply. You can't mandate certain things when you don't have the supply, or if you have the supply, you don't have the capacity to deliver. We've all seen these long lines of people waiting to get vaccinated. And even now, I don't think if everybody agreed to get vaccinated in the next few weeks, Pakistan would be able, at least in Pakistan, we would be able to vaccinate everyone who would be doing so. The second, apart from the necessity part of it, there has to be about the proportionality part of it. So you have to decide a mandate is effective in protecting. You have to choose the least possible and the least intrusive, and that's the least infringement method. The question is, if you would consider masks versus vaccines, at least for spread, the masks are clearly less intrusive in that sense. They don't invade a body, you don't inject something to it. It's uncomfortable, it's not easy to wear, and clearly not easy to mandate, especially in private places. So that's why it's probably maybe easier for people to get vaccinated. However, you may have other options available to spread. Then there has to be a reciprocal obligation. So if I tell people to get vaccinated and mandates, what happens if I have an allergic reaction to the drug? What happens if I need to be admitted to a hospital? What is the reciprocal obligation of the state or the government that mandates it that would do? Do I get a no-cost treatment? The authority that has mandated, would it then help me? What if I die? What if I'm the only solely earning member of my family and I die because of a vaccine, a rare event of the vaccine? Who compensates, or whether will I be compensated? When society mandates or asks people to do certain things, there has to be a reciprocal obligation on those things, on the authority that does it, to at least have some reciprocal effect. The fourth part is about the public trust and its justification. One has to be very careful when we give mandates for vaccination, because when you are told to do certain things by stick, people get very wary, and people are always wary of coercive power of the government and how they try, or how governments would try to use them. And so you have to be very sure whether we'll be able to, once you mandate it, it not only sometimes has an effect on for the COVID vaccine, you may have an effect of public health, erosion of trust in public health for other areas too. And so you have to be very careful with that. As I mentioned, transparency is an extremely essential part of how, why, and who does the decision making, who were the parts of decision makers, and how the decision was achieved, and was enough reasonable things done so that vaccine mandation is not done. I mean, ideally, one would like people to get vaccinated themselves because they choose to get vaccinated. And so the issue of how much of public engagement has been there and how many stakeholders have been involved in it. It's nice that a lot of religious people have done it, but it's not just the religious fatwas that are required. There are a lot of other people who don't use it, and there are a lot of counter fatwas that are always available that people would go through. So in conclusion, the word mandate, I think sometimes is also used rhetorically. Mandates should only be done if other measures fail, like engagement and education. We should try to have the least intrusive mandate if possible. And the question is how safe these vaccines are and why they are still on emergency use authorization. And enforcement and mandates, unfortunately, always erode the public trust. Not only public trust, but also individuals feel that they have been, in some ways, been forced to do things that they may not do. And ideally, they should be used as a last resort. And thank you very much for your time.
Thank you so much, Dr. Asim. That was a fantastic insight into trying to understand a little bit more about what mandates actually really are and how they impact on public health. And thank you so much for highlighting the fact that there's a difference between a mandate and a vaccination policy. And I think what we've been seeing recently in Pakistan is the implementation of various vaccine policies on behalf of the NCOC. So I think again we've got an interesting confusion about the use of the word mandate. But thank you so much for clarifying that. We've got lots of questions coming in regarding the whole concept of mandatory vaccination, and I'm going to therefore quickly move on to our last talk so that we can come back and answer some of these questions. And I now would like to invite Dr. Faisal Mahmood for the last talk of the webinar. No jab, no job. And this is really trying to, again, give some insight into vaccination policy and how coercive and intrusive they can be. So Dr. Faisal is Associate Professor and Section Head of the Department of Infectious Diseases at the Aga Khan University in Karachi. Dr. Faisal, I'm going to hand over to you now.
Hey, thank you. Thank you so much for having me. And also, thank you for this. I mean, I love the topic, no jab, no job. I mean, whoever came up with this was really smart. So I'm not going to take too long, actually. I can also see lots of questions. A lot of things have been spoken and talked about already, but just want to talk about the job and the vaccine issue. And really, it does boil down to what everybody's been talking about, which is, how much of putting limitation is coercion. But when you talk about jobs, I think, it's really important to distinguish between the two types of jobs you're talking about. There's those healthcare workers and then the non-healthcare workers. And in both cases, do the same rules apply or not? So for the healthcare workers, in other words, should a healthcare worker be denied a job or denied coming to work if they've not been vaccinated? So here, there's actually more dimensions to what happens if a healthcare worker is not vaccinated. Because remember, a non-vaccinated healthcare worker who may be at high risk of developing an infection is also at risk of transmitting the infection to the patients. And actually, this has been endorsed by many societies in the US also, that it's probably unethical for a healthcare worker not to get vaccinated. because this doesn't fulfill the ethical commitment of providing safe care for patients, and not just healthcare workers within the hospital, but also healthcare workers working in places like long-term care facilities, where a COVID infection could be devastating for the people working or the residents actually. So in terms of healthcare workers, getting the vaccine or mandating the vaccine, and I'm mandating in quotations here, is probably maybe justified. But when we talk about non-healthcare workers, it becomes a lot more murky, because over here it's the same. Does the common good trump individual rights or not? And there have been threats to block salaries. In fact, in the government institutes in Sindh, at least, you need to be vaccinated, otherwise you won't get a pay. A lot of private institutes have done the same. Nobody's been fired, to my knowledge, so far because they haven't been vaccinated. But yes, their salaries may be blocked. But this is sort of debatable, because when you make sweeping statements like, there are untoward effects, and that's what we're seeing currently on the ground as well. And these could be things like people getting fake vaccination cards, which is surprisingly and unfortunately surprisingly easy to get. And people who cannot get the vaccine for various reasons really don't get, may lose out on a job, and they may not get a vaccine because of medical reasons. They may not get it because of logistic reasons. For example, when you talk about vaccination currently in Pakistan, it has been linked to the national ID card, and if you don't have an NIC number, it is or was really difficult to get the vaccine. And then obviously physical slots. We have, just 2 days ago, somebody had called me that they need to get the vaccine, but the lines are so long in the vaccination center that they just can't go and get the vaccine. So really, but on the flip side, obviously, without the additional motivation, it's really difficult to reach out to the general population. So just to sum up, and I kept it short so that we could keep some questions in. I think it is exactly what Paul had mentioned. At what level of coercion or what level of putting in mandates would then become coercion. And for jab, no job, for healthcare workers, for me is relatively simpler, but for non-healthcare workers is a little bit more murky. Thank you.
Great, thank you, Dr. Faisal. Yes, extremely murky. I don't know whether we're going to be able to clean that water and try and get some clarity, but the idea behind today's discussion is really to try and maybe familiarize ourselves with some of these challenges, and to try and at least in our own minds, when we're talking to family and friends and colleagues, perhaps have a better idea of which direction we need to move on in terms of the message that we're conveying. Because what seems to be very evident over the last couple of weeks is really, what are we saying in terms of how effective and safe these vaccines are, as Dr. Bushra started off and she's informed us, but how effectively is that message getting across to people? And the fact that in Karachi a few days ago, the threat to block SIM cards really compelled an enormous, I mean, we had over 1 million vaccinations that day. And so to sort of, it doesn't seem to me that these people were scared as such, more complacent, and perhaps didn't realize how much of a serious issue this was to be vaccinated. So we thank you so much to all of you for excellent talks, and we've got an enormous number of questions now. I'm going to start off with a question for, sorry, let me just bring that, bring the question slides up. Okay, the questions are rolling in. They're still rolling in from Facebook, but just to quickly start off with, Dr. Bushra, seeing as you were one of the first talks, there is a question asking about the statistics available for adverse reactions to different vaccines in Pakistan. And I guess as in terms of transparency, as Dr. Asim was just saying, there's a question here asking about whether or not those statistics should be made more public as to adverse events from vaccines in an attempt to try and, again, convince people that it's actually not that bad, and to stop some of this rumor mongering?
Okay, so I don't think that data regarding adverse reactions is optimal as such, because many people do not know how to document adverse reactions. So whatever is captured, it is mostly the adverse events which take place immediately after vaccination, because there is a post-vaccination observation time which is given at different vaccination centers. And because of crowding, mostly people are not retained for a specific period of time. And then it has always been difficult to capture data once the person goes away. And people do not take this trouble of calling the vaccination center back to report any adverse events. So what is known so far is that there have been no deaths because of vaccination, no immediate fatalities. So that is all that is reliably known about the adverse events, and most of the adverse events which have been reported are of minor nature. So when this data is again discussed, I will copy a few slides and present it in one of the coming sessions.
Thank you, thank you, Dr. Bushka. Thank you very much. We've got a question here for Dr. Lombardo. Dr. Lombardo, thank you for a wonderful talk. I'd like to know that in the absence of data regarding long-term risks and side effects of COVID vaccines, would it be legally and morally justifiable to make vaccination mandatory? And in such cases, what are the ethical reasons to impose restrictions on non-vaccinated people?
Well, I think the legal part is easy to answer, because at least in most countries, you're going to have a Ministry of Health or some regulatory body whose job is to determine whether or not the vaccine is safe and effective, and they will make that announcement. It's a judgment call. It's sometimes controversial, and sometimes there are disagreements, but that group is going to make a decision of whether or not to release a vaccine for public use. So legally, that can happen. The harder question is at what level of risk should that group or any other group accept as being appropriate when they are urging people strongly, in some cases actually pushing people to take the vaccine. And it seems to me that there's an inverse relationship between the risks that you face and your willingness to accept those risks. So we know that the risk in some of the vaccines is vanishingly low. In this country, the problem in the past, not with COVID, but with other vaccines, has been that the vaccines were tremendously effective for measles, for example, or for smallpox, which we wiped out. But there were some people who still didn't want to take it, and they were able to avoid it because there was so little of the disease around that it wasn't a public health threat. This is a different situation because the COVID vaccine clearly is killing, the COVID disease is killing people all over the world in large numbers. And almost as importantly, it is devastating the lives of people because they can't get jobs, or the jobs disappear, or the economies collapse. So that becomes a public health issue also, with lots of political ramifications. So I'd say that ethically, I think that when a reputable public governmental body has approved a vaccine, we should have fewer problems with it, as long as we're really trusting that body generally.
Thank you. Thank you very much, Paul. So moving on to another question, and this one is for I think it's for Dr. Asim. Dr. Asim, this is from Sandhya. She would like to know if it would be interesting to understand the argument in favor of mandatory vaccination when the vaccines are not widely available and they don't stop transmission. So I think you did mention this a little bit during your talk, but I think maybe just to reiterate that point.
So the question is, if one has to be, as I said, one has to be really sure of why we are mandating the vaccine. What is the public health outcome that we are looking at? If the public health outcome is to make sure that your system doesn't collapse, the healthcare is not overburdened, people are still able to go back to job, you have enough healthcare workers to do the job, and your economies don't go down, you don't have to put a lockdown. That is just one way of justifying it. However, the other objective that sometimes we use is that when we keep saying that it helps the spread of disease, unfortunately, it may not be that specific. I mean, we are still not sure. And clearly now a lot of data is available. As Bushra mentioned, that clearly the spread or not getting the disease is not, unfortunately, it has not happened as much as we would like it to happen. So therefore, even when Faisal was saying that healthcare workers should, it's clear for healthcare workers to get the vaccine because they're going to get the patients infected, that may not be 100% true. My concern is, I mean, I know I work at an institution where there are people who have had a renal transplant, people who come on dialysis, and they keep asking whether the technician has been vaccinated or not. And the question is, if the fear is that the technician is going to give you disease because he has not been vaccinated, I think the fear should be also that even if he is vaccinated, he can still transmit, because they may have, as everybody has said, that you can have some disease which is not there. So therefore, it's so mandating vaccines for a different purpose for public health, as Paul was mentioning, I mean, that may be acceptable. But when we keep saying that it will help the spread of disease, and so therefore, why you can't travel on an aircraft? Because I mean, the presumption is that if you have been vaccinated, you're not likely to spread it to other people. That may not be that true. And so if at the end of, say, next month we say, yes, of course it does not do it, and so therefore what we've been saying about 3 months ago was wrong, then the public trust goes away completely. So my concern is twofold. One is its mandation, of course, is unfortunately sometimes necessary. Ideally, it should be the last thing to do. And the second, we have to be clear why we are mandating certain things. If it's not the spread, which I don't think is the spread, I mean, there's no data to suggest that getting vaccinated would help prevent illness, and Faisal can correct me completely if I'm wrong, then it's the other option. And the other option, you don't really have to vaccinate healthcare workers. I mean, it becomes as murky for healthcare workers as for not healthcare workers.
Thank you, Dr. Asim. I'm going to ask Dr. Bushra to comment on this, because I think that, you know, that she did make a point about this in her presentation about the importance of vaccines in transmission. So, Dr. Bushra, would you like to comment on this question as well?
Yes. So there is still a debate going on whether vaccines slow down the transmission or prevent it. So newer data suggests that there may be some impact on disease transmission as well. So vaccines do not completely block transmission, but people who are vaccinated are likely to share fewer viruses as opposed to somebody who's unvaccinated. So the benefit of vaccine is not absolute, but whatever benefit the vaccines are giving, we should make full use of it to actually block the pandemic, which is just going on and on.
Thank you, Dr. Bushra. Dr. Faisal, could you also comment on this question?
Yeah, sure. So I agree with, you know, it's not as cut and dry that vaccines don't prevent transmission. You know, so if you just look at it from what we know so far, is if vaccines cause people to have less symptomatic disease, and we also know that people without symptoms transmit the virus less. So just by that simple logic, it'll reduce transmission. But remember, with everything we do with COVID-19, each of these precautions that we take, be it masks, physical distancing, overcrowding, vaccines, these are all layers for prevention. No one mechanism is what's going to prevent you. So there's just one additional layer, which just like a mask, really is a vital one.
Great, thank you so much. And I think that again sort of reflects the fact that how we're also presenting this data and what people are taking away from a lot of the data and the evidence that's out there, normally through social media. But the fact that it talks about absolutes, doesn't it? It talks about does vaccination stop transmission? Well, it may stop a proportion of transmission. So rather than looking at a yes or no, we're looking for a yes or no answer, rather than trying to understand it from a scientific point of view, that we should be looking at the numbers rather than actually looking at a yes or no answer. Thank you so much for that. We'll move on to another question. So there are lots of questions coming in related to ownership by the state, and especially the issue of the state actually reciprocating the obligation of a citizen to be vaccinated by protecting that citizen if there are any consequences of that vaccination. So the question here is that it was an important point raised by Dr. Asim Ahmed, but is it realistic in our context? Does the government have any plans to fulfill reciprocal obligations in case where healthcare workers or public sector employees have an adverse reaction to a vaccination? And this question is to Dr. Bushra and to Dr. Asim. So I'd like maybe Dr. Bushra to take this first. Is that okay?
Yes, thank you. So this reciprocity, yes, and ethics. These points are actually discussed whenever decisions are being made in NCOC. So there is a mixture of scientific discussion, data review, and then the ethics of it. And I think I've been very pleasantly surprised. The government's approach has been very benevolent. So if any such issue is brought up, it is considered very carefully. Nothing is brushed under the carpet. All the decisions which have been made have not been made in isolation. So there are several layers of discussions, consultations, and then a decision is made, and then again it's discussed whether it's in the best interest of the people. So I think it is fun to work with the government, which is quite surprising, especially for COVID, because all the decisions are vetted, examined objectively, and then taken, and then public health interests are kept supreme. So that's what I've seen. This is my personal observation.
That's really good to know, Dr. Bushra. That really gives me a lot of hope. And Paul, would you like to comment on this before I go to Dr. Asim?
No, I think we covered the ground. No.
Okay, great. Dr. Asim? I think, is Dr. Asim still there? I'm sorry, I can't see him.
He may be frozen. You may carry on.
Okay. Okay. All right. No. Thank you, Dr. Ahmed. I think I'll carry on to our next question. So we've got a very important point, and maybe Dr. Faisal, you could answer this. There's a lot of discussion going on about mandatory vaccination, but medical exemption is really important, and the audience member who's asked this question is basically saying, please discuss the medical exemption to mandatory vaccination. Threats of punitive actions like stopping salary or shutting SIMs is causing huge stress to many who could not risk vaccine because of certain side effects or medical conditions. And there's currently no legal domain or any other way to challenge them for not being able to exercise their autonomy and their own right to decide whether or not they take the vaccine.
Thank you. So this is actually something we deal with in our institute also all the time, to exempt or not to exempt. And I think over here there are actually two issues. One is, or three perhaps. The first is, is the medical exemption really an exemption? So in other words, is the person really medically exempted on true medical grounds? And I bring this up because we get people or women who are pregnant and ask for medical exemption, saying that they're pregnant and they want to be exempted from the vaccine. And in this case, it's more of a perception, either both in terms of the person who's going to get vaccinated, but also the healthcare worker who they're going to, because sometimes or often the healthcare worker may not know if there's an exemption or not. And I think over here it boils down to communication and talking to people and trying to sort of explain to them what really is an indication or an exemption for vaccination. On the other hand, there are conditions where you cannot vaccinate or you need to postpone vaccination for various medical reasons. And over there, I think medical exemptions work. But the biggest issue here then ends up being logistics, because sometimes, if I write a certificate that, this person does not need to be vaccinated or should not be vaccinated at this point, it may not be honored at the other end at the job site. And there is no really clear mechanism at this point. And this brings up a really important point. And thank you for the person asking the question, is that whenever we make these regulations, we need to sort of keep in mind these other put in mechanisms where people can have exemptions put into place, which we often sometimes forget because they are tougher to do.
Thank you, Dr. Faisal. Thank you so much. Dr. Asim, are you back online? Can we?
Yes, he's joined.
Yes,
He's joined. Okay, great. So we're back to another question for, I think this is for all the panelists. So we seem to be naive to support restrictions or mandating because we haven't established whether vaccines are definitely or ultimately beneficial. Why can't we argue that this, the vaccination is at present our best proven tool? One has to trust whatever is present at that particular time. Isn't that the case? Do we have Dr. Asim, would you like to take this one first?
Yes, I will. That's true. The question is whether you should give the person the choice to decide whether this is the best option available with the best science available, or is there does it have to be mandated? The question is not that whether the vaccines should be taken or not, and clearly there's evidence that getting vaccination or getting vaccinated would help. The question is it when it's being mandated for certain things? That becomes contentious. So clearly, it's still so if you look at normal vaccine development and if you look at normal vaccine authorizations or registrations, it takes a long time. And the reason it takes a long time because you need to know long-term effects, both good and bad, and that has not been done. And therefore, all these vaccines in each country have still not been registered. And the question is, should you then just leave it to the personal choice of deciding these options, or you give a mandate? The question is, as I think Paul mentioned, I mean, clearly wearing a mask in the aircraft is going to be much more helpful than if you are vaccinated and not wearing a mask. Doing both those things may be even better because, as you said, there is less virus. But the question is, what do you mandate first? The question is, if it becomes so difficult to mandate masks, therefore it's much more easier to give a jab. And the problem is that, of course, we still don't have enough jabs available, I mean, at least in Pakistan. And my other concern, of course, is that we've now created different layers of like we have social levels, we have now levels of vaccines. So if you have a Chinese vaccines, you are less likely to go to the US. For example, you can't go to UK with a Chinese vaccine without.
No, I can't. I have to quarantine for 2 weeks. Yes, in a hotel, which not a very nice hotel that I'm told. Yes,
and on your own expense. But if you probably have a mRNA vaccine, you probably may not need to do that. And so the whole question is that we've now created 2 layers. Unfortunately, public health, as I had mentioned, has a lot of political ramifications too, both internally. I mean, you can see it in the US from the federal government and state levels, depending upon which state level you're talking about, and you see it here in Pakistan. So when you say NCOC works great, and it probably does, the question is that the state government doesn't think it works that great. It thinks that it does it exactly opposite. So it depends upon in which committee one is sitting down to see. So there are political ramifications, and one has to do this. So therefore, you have to decide, how do you actually mandate certain things and say, no, you have to use it, although you don't have enough evidence for long-term. And that's the question.
Thank you so much. I'd like to ask Dr. Faisal to comment on this question.
Can you repeat the question? My signals got lost in the middle. Sorry.
Oh, no, sure. So it seems that we have, sorry, I think I've lost my screen. Just 1 second. Right, so we seem to be naive to support restrictions or mandating because we haven't established whether vaccines are definitely or ultimately beneficial. Why can't we just argue that this vaccination is at present our best proven tool? So one has to trust whatever is present at that particular time. Isn't that the case?
It is, and agree with Dr. Asimov, but also, again, coming back to the same point I made a little while ago, that it's not the only way to prevent. So putting all your eggs in the vaccine basket really is not the right way to go. You know, but it also does not mean that you abandon vaccines or say that they're not useful. It's just that it's vaccines and masks and everything all to sort of put together, and that's what we need. So the mandating is hard. And doing and masking is actually sort of an easy, cheap way to do it, but that does not mean that you that it's not, like, masks is not the only thing either, right? It's masks, and distancing, right? So that's the thing.
So thank you, Dr. Faisal. Dr. Bushra, I mean, I think that this is really kind of coming back to this whole idea that it's not just vaccination that's going to contain and mitigate this pandemic. We're going to need to use everything that's available to us. And I think, again, the idea that, at the moment, some new data that's coming out that vaccination doesn't, it can also, if you're vaccinated, you can also transmit the infection. So would you just comment on this question?
Yes, the risk is there. This is a new infection. It has defied everything we've known so far.
Yeah.
And we were waiting for robust immunity to develop after the first wave. And we didn't talk to our veterinary colleagues who actually swear that how it behaves in the animal world. So we were ill prepared. We do not talk to our colleagues. And we've been taken by surprise. So as long as the pandemic lasts, the best strategy is just to stick to the protective measures which have worked so far. Because the whole of 2020, all of the frontline healthcare workers were working with the masks on, with the shield on, with the gloves on. And that is what protected us, because we were dealing with COVID patients day in and day out, and we were not vaccinated.
Yes.
And I think the safest bet is to just stick to the measures which are proven, which protected us despite being vaccinated. Because this phenomenon of the immunity against COVID is also a little complex. So even doctors have a simplistic view about it, because they may go and get their antibodies checked. Although it has been explained time and again that antibodies do not solely reflect a person's immune status. So immunity to coronaviruses is complex, and then the virus evades the immune system because of mutations in the key antigens. So as long as we have this pandemic going on, the safest bet to protect oneself is just wear proper PPE.
Yes, absolutely. So until we catch up with our vaccination rate, it's really, really critical that everyone continues to keep using their PPEs, whether you're in healthcare or anywhere else out in the community. So thank you very much, Dr. Bushra. So we've got maybe a few minutes left. So I'm quickly just going to wrap up and thank our panelists. Thank you so much for an, really, I think we've got one more. Oh, we've got time for one more question. Sorry. We've got a question from Dr. Mozum. Oh, wow. Dr. Mozum. A pandemic by its nature is a global phenomenon. It would seem to me that local national efforts are fine. The elephant in the room is the failure at the global level to see it as such, where availability of vaccinations to 4 countries is concerned. And here we're discussing the mandatory efforts are needed at local levels. I would like to have Dr. Bushra, seeing as you're online, would you answer that question?
Yes, so this is actually the inequity of vaccine distribution throughout the world. And even today, news has come that France and I think Germany are going to introduce booster doses. So although half of the world has not received their first doses, and all the rich countries actually hoarded vaccines. And one of the reasons why Pakistan is getting Moderna now is that it's close to its expiry date. So expiry may be in November, but that's not acceptable for the countries which hoarded it. So they are willing to give it to us. And we are willing to take anything and everything which may offer some protection.
Some protection, yeah.
Yes, some protection. And this is what everyone has worked for so far. You should see the efforts which are made every single day to increase vaccine procurement. There are so many people running after different groups, different companies, different countries to get as many vaccine doses as possible to sustain this upscaling. So that's where we stand.
I'm going to have Dr. Mozam, you've raised your hand. Please unmute. Dr. Mozam, you're still on mute. Could you unmute?
Sorry about that. So just the comment that I made, I find it interesting that the apartheid system that is very much there and is building up as far as vaccination is concerned, Dr. Asim had responded to that also. So we talk about ethics, we're talking about what would be ethical in Pakistan and elsewhere. But one would think that there is, as I said, the elephant in the room is the global effort. And I think it's been abysmal, pitiful to say the least, how the world has responded to what is a pandemic. So that is just a comment. WHO is busting its chops, etc. But I think the facts are in front of us. Thank you.
Thank you, Dr. Mozam. Dr. Asim, you had raised your hand, just a 1 or 2 minutes left. Did you want to make a comment?
Yes, apart from the fact that the distribution globally has been really horrible, then in fact, the worst part was that one of the WHO expert groups said that you can actually now do placebo-controlled trials in these countries since they don't have the vaccine.
Right.
So you get whacked once from one side and then you get whacked the other way around. So because you don't have the vaccine, it's ethically acceptable to get a placebo. I mean, so it's not only abysmal. And unfortunately, it's not going to work globally. You can have a third booster or whatever. It is going to come back and bite you. You know where? It's not going to go away. And you're right. I mean, I recently somebody sent me a text message saying if you want Moderna vaccine free, it's available, and it is only because as Bushra said, the last date for Pfizer is September. For Moderna, it's November. So they're all expiring within the next 2 months. So anybody who wants to get it can get it free, can get it easily. So the only reason you're getting that vaccine is because they don't want to use that vaccine because it's too close to expiry date.
Yeah.
That's incredible. Well, thank you everybody for joining us today. Thank you panelists for taking out time and sharing your very important and expert views with us and really enlightening us all to understand this the challenges that we face right now in terms of vaccinating and vaccination in Pakistan. I'm going to just quickly summarize. It is going to remain a challenge. This isn't going anywhere. As Dr. Bushra has said, what is happening in terms of how coronaviruses generally behave in animals and how it seems to be behaving the same in the human population. So it's not going anywhere. But I do want to just say that as it's coming close to 14th August, next Saturday, which is Independence Day, we really are going to have to change the message. I think so, another participant, Mariam, had asked in the chat again about the amount of public engagement and how are we communicating with the public? Are we listening to them? Are we actually listening to some of their concerns and fears and trying to understand why vaccine uptake is so low? And if we do that, we may not have to go towards mandatory or any other vaccination policies. I know in Spain, they haven't even had to worry about this. It's been over 80% acceptancy rate in Spain. So we perhaps need to look at other countries and see what sort of, how they're engaging, how are they promoting vaccination for COVID-19. So in spirit of Independence Day next weekend, I just wanted to share this one, a very important quote from Muhammad Ali Jinnah in 1947. "We're going through fire, the sunshine has yet to come, but I have no doubt that with unity, faith, discipline, we will compare with any nation of the world." And I do hope that's true. That's why we've got the injection there in the background and the PPEs. So with that, I'd like to say thank you to CBEC and to MMIDSP. That's it from me. Thank you.
Natasha, thank you very much. Workshop very well. Webinar excellent. An excellent closing. I think I can't say anything beyond this after you've quoted the Quaid-e-Azam and the correct quote from Unity, Faith and Discipline. That's what he said. I think we've all summed up very correctly that while vaccines are important and the mechanisms can still be debated, but their importance cannot be debated. They're important, as are physical distancing as well as masks and everything else. So with that take-home message, I think I would like to thank all the panelists and all the participants. We've had a very, very good participation from across the globe. Although it was focused in Pakistan, but it's been a very, very good participation from across the globe. Thank you all for making this a very successful interaction. And thank you, panelists, for giving us your time. I know all of you are very, very busy. And you made time for us. Thanks a lot. Thank you, everyone, and goodbye and Khuda Hafiz.
Khuda Hafiz. Swaliha, thank you, Swaliha, and everyone at CBEC for sorting out the questions. It was great. You were feeding them really well. Thank you so much for all that support.
You're welcome. It was mainly Freddie doing it.
Thank you so much.
Thank you.
Okay.